And the first debate is going to be, do all patients with intermediate uveitis need treatment? And we have talking for it, Dr. Mudit Tyagi, who heads the uveitis and ocular immunology services from LV Prasad, Hyderabad. And arguing against it is going to be Dr. Reema Bansal, who's the additional professor, again, Uvea and Vitreoretina Services from PGI Chandigarh. And let's hear these dynamic speakers tell us something more about what we need to know about treating an intermediate uveitis patients. On to you, Dr. Mudit.
Yeah. So I'm audible, I believe.
Yeah.
Yes.
Just one second. I'll just. Are my slides also visible?
Yes.
All right. So first of all, let me thank the Aios Scientific Committee and all the conveners of this panel for giving me a chance to speak on this topic. Now, what I am talking about is, do we treat all patients of intermediate uveitis, and who are the ones who definitely do need treatment? Now, the question that we have is to treat or not to treat. Now, before we go on to the question regarding the treatment of these patients, what we need to understand is that intermediate uveitis is that subset of uveitis where the major site of inflammation, the nidus, the point which is inciting everything, that lies in the vitreous. So vitreous is a major site of inflammation. And if you look at it, while Western literature says around 1.4 to 2.2%, 22% of all of uveitis and intermediate uveitis, what we see in India ranges from something around 10% to 18%. It affects all age groups, usually in the 3rd to 4th decade. However, in pediatric subgroup, it is around 10 to 12%. There is no gender predilection, and nearly 70 to 80% of these patients may, even though if it's asymmetric, have a bilateral onset of disease. Now, what we do also see in intermediate uveitis, apart from vitritis or vitreous involvement, sometimes is a cystoid macular edema, peripheral snowball exudates, snow banking inferiorly, and sometimes this snow banking become extremely confluent, and you may also sometimes see peripheral neovascularization. Now, traditionally, what has been told to us is that what are the indications for treatment? So, a visual acuity less than 20/40, cystoid macular edema, vitreous haze, and vasculitis have till now been the conventional indications for treatment in a lot of these patients. But occasionally you may have patients who are falling outside the spectrum of these. And let me show you one example. So this was one patient who came to us with a decrease in vision in the left eye, and the OCT showed us the presence of cystoid macular edema. But though the vision was 20/32, this patient ultimately turned out to be positive for syphilis and thus ended up with treatment for syphilis. So the point is that apart from the vitreous manifestations, a lot of times intermediate uveitis can have underlying systemic diseases like syphilis or tuberculosis. In infectious causes, you may have systemic associations like multiple sclerosis, sarcoidosis, and these diseases in itself do need a treatment. So saying that you are only supposed to treat a patient who falls into that particular subset is taking a too simple approach towards how things may be in uveitis. So if a patient has got an underlying systemic disease, even these patients do end up needing treatment. And though my opponent in this disease debate over here will probably present some other views, but the fact is that one of the largest studies which actually came from their parent institute also showed that a lot of these etiologies are secondary to TB or multiple sclerosis, and timely management, and this is the important word, timely management of these patients leads to an improvement and stabilization of vision in 93% of eyes, with 70% achieving a final visual acuity of 20/40 or better. So while we do come back to the point of 20/40, the important word over here is timely management. And why that becomes important is because what happens if you do not treat these patients in time? If you don't treat these patients in time, because of the chronicity of the disease, you end up with this plethora of complications. Glaucoma is known to complicate 7 to 11% of these cases. You have a high incidence of cataract in these patients. Cystoid macular edema, something which we have already discussed. ERM, vasculitis, peripheral neovascularization, retinal detachments which may be exudative, fractional, or even sometimes rhegmatogenous. And also sometimes if this peripheral snow banking leads to secondary membrane formation, then even an intractable hypotony. So how do you avoid these complications? You avoid them by treating them in time. Apart from that, what we have to realize is that even though the posterior pole examination may seem to be cursory, but frequency of vasculitis is variable, ranging from 17 to 90% in multiple studies. You may have neovascularization because of ischemia which is happening. That may lead to vitreous hemorrhage detachments and cyclitic membrane formation. And while you may see these peripheral areas of vasculitis and inflammation over here, a peripheral OCT angiography or even an FFA may reveal the presence of peripheral areas of non-perfusion and peripheral neovascularization. And again, these patients, even if the vision is good, may end up needing a treatment. Apart from that, optic disc edema also is seen in 70% of cases. When we do an efflorescent angiography, you may find disc leakage in a lot of these cases, which may otherwise end up having a good vision, but still you need to treat those patients. So my concluding statement over here is who finally does need treatment. Patients who present to you with a decrease in visual acuity, not just 20/40, but even patients who may have a decrease from their earlier 20/20 to now even 20/32. Patients with underlying cystoid macular edemas, underlying infective diseases, vasculitis and other complications which we have mentioned. So the important word in all diseases when we talk about it, not only in ophthalmology, but everywhere else when it comes to medicine, a stitch in time saves 9. So treat these patients in time and you may end up avoiding a lot of these complications. And with that, I rest my case. Thank you so much.
Thanks a lot, Dr. Mudit.